My dear colleagues, welcome to our Congress. I am the coordinator of International IYAC Academy of Cardiology and board member of Cardiovascular Academy, Tuğba Kemaloğlu from Istanbul, Turkey. It's a big pleasure for me to be a part of this interesting session with global experts in field of cardiovascular imaging. I am going to moderate this session with my mentor and teacher, Prof.Dr.Navin from United States. He is a both nationally and internationally renowned cardiologist and director of Heart Station Echocardiography Laboratories at the University of Alabama in Birmingham, and editor of peer-reviewed journal Echocardiography. Welcome, Professor Dr. Nanda.
Thank you so much. Thank you very much. Great pleasure to be here. Okay.
Thank you. And I would like to introduce our first speaker, Dr. Corrado Fiore from Lecce, Italy, who is one of the best new generation cardiac imagers and dedicated to the mitral valve, and going to talk about as all you expected mitral valve assessment in advance.
Good afternoon to everyone. I am Corrado Fiore from Lecce, Italy, and I would like to thank board of IYAC for inviting me to this great congress. My lecture is about mitral valve assessment in advance, and I will talk about some tips and tricks in the context of surgical mitral valve repair. I like to start with some words from one of the biggest mitral valve surgeons in the world, Alain Carpentier, to understand how it's complex sometimes to recognize the mechanism of mitral incompetence. So the mitral valve is like a woman. The more you try to understand it, the less you understand it. Before to send the patient to the surgeon, we need a detailed valve analysis. So we should know the size of the valve, the segmental leaflet height. We have to look at the commissure and the clef. We have to look at the chordal condition. We have to know annular geometry, and of course, ventricular shape and function plays an important role. Everything starts with the pathophysiological triad. In many reports, we can read patient as a flail, patient as a prolapse. But what is the prolapse or the flail? Prolapse or flail is just a dysfunction of the valve. We have before the etiology, I mean the cause of the disease, then the lesions, I mean the result of the disease, and then the dysfunction result from the lesion. For example, Barlow is the etiology. The lesion will be elongation chordae or rupture chordae, and then the dysfunction will be prolapse or flail. So a comprehensive understanding of valvular disease implies a clear distinction between etiology, lesion, and dysfunction. Everyone knows the Carpentier's functional classification with three types. Type 1, patient with annular dilatation or leaflet perforation. Type 2, a wide spectrum of the degenerative mitral valve disease. And type 3, 3A, patient with restricted motion of anterior and posterior mitral leaflet in both systole and diastole, for example in rheumatic valve, and 3B, patient with a functional or secondary mitral regurgitation. I want to show you some cases. Type 1, patient with annular dilatation due to a long-standing atrial fibrillation. We have a central regurgitant jet in the intraoperative TE, and in most of cases, this type of repair requires just an annuloplasty. Another example, always a type 1 patient with a leaflet perforation. It is a case of a patient with endocarditis. We can see a vegetation on the aortic valve and a kissing lesion on the anterior mitral leaflet with an hole in the clear zone in the body of the leaflet, as shown very well from 3D echo, and then we have also the intraoperative finding. What about the degenerative mitral disease type 2? On one end, we have a fibroelastic deficiency, I mean a valve with a lack of tissue, thin leaflet, thin chordae, and most of patients has chordal rupture. On the other hand, we have a Barlow disease, I mean a myxomatous valve with a leaflet prolapse and annular dilatation, and look at the correspondence between the pictures above and the 3D echo below. 3D echo is an important and a crucial tool to recognize, to understand the anatomy and the anatomic features of the valve. In the first video, we have a prolapse of A1 scallop. In the second, in the context of fibroelastic deficiency. In the second video, we have a chordal rupture on P2 scallop. In the third video, we have a form thrust, and then at the end, a Barlow disease with a prolapsing valve and a multi-scallops valve. In order to reach the best result for the patient and the best repair, surgeon and echocardiographer should talk the same language, and it is possible just because of 3D TE. It's the atrial perspective of the mitral valve for the surgeon, and it is the atrial perspective of the mitral valve by echocardiographer. So anterior mitral leaflet, posterior mitral leaflet, anterolateral commissure, posteromedial commissure, and at least three chordal rupture on a huge P2 scallop. 3D echo is very important to assess the mitral valve and to choose also the best surgical strategy for repair the valve. Now we know there are many software that give us a lot of information, for example, tenting height, annulus area, tenting volume, leaflet area, and each information is very important for the strategy of the surgeon. Many surgeons choose his surgical strategy according to these measurements. So we need it, of course. What is the philosophy of mitral valve repair? It's not only important to learn the basic principle and technique of mitral valve repair, but also more important to know how to produce a long-standing repair. If I'm sending a patient to repair, I need a repair forever. So I need the best result for my patients. And in order to reach the best repair, we should respect some rules. I mean, we have to restore a native annular dimension. We have to restore a coaptation length at least 8 millimeters at the level of A2, P2. We have to restore a coaptation depth, and we have to achieve an harmonious closure line. What about restore the native annular dimension? We need, of course, the annuloplasty. Because annuloplasty, we can restore annular size and geometry. We can prevent future annular dilatation. We can increase leaflet coaptation. We can reduce tension on sutures. So the prosthetic ring is very, very important for the success of repair. There are two golden relationships: to restore the shape and to restore the size. We know mitral annulus has two diameters, the anteroposterior diameter and the intercommissural diameter. In a normal orifice, intercommissural diameter is longer than anteroposterior diameter, but we have some mitral disease, for example, in ischemic mitral valve. There is a distortion of the annular geometry and the orifice became more circular. So anteroposterior diameter will be the same, will get the same height and the same length of intercommissural diameter. And because annuloplasty, we can restore the geometry, the shape, and the size of native annulus. In this way, we will restore also the coaptation length. We said at least 8 millimeters at the level of A2, P2 scallop. And then, of course, to achieve the best result, we need the ability of the surgeon as well. And one of the best motto of the surgeon is respect rather than resect. Of course, it's very important to respect the leaflet mobility. There are many surgical techniques: quadrangular resection, triangular resection, folding plasty, sliding plasty, neocorte implantation. But we have to avoid excess resection, we have to avoid tension, and we have to avoid distortion of the leaflet. At the end, we have to achieve an harmonious closure line, a line of closure parallel and proximal to the posterior leaflet attachment means a satisfactory valve reconstruction. So we will get a large surface of leaflet coaptation far from the LVOT. So it is the closure line posteriorly, and with the mitral valve in closed position, the ratio between the visible atrial area of anterior mitral leaflet and posterior mitral leaflet should be 3:1. I want to show you some cases. First case is a young man with a Barlow disease. As we can see from 2D, 3D TE, we have a B-leaflet prolapse with a MAD. Very important to recognize this entity because of malignant arrhythmias or sudden cardiac death, multi-jet of regurgitation, and also 3D show us a myxomatous valve with anterior and posterior leaflet prolapse. What about surgery? I want to show you some intraoperative video. In the first video, the surgeon is placing the sutures through P2 scallop, and then he will measure the neocord. It's very important in this moment because we should avoid to implant too short or too long neocorder in order to avoid in the post-operative tethering or still the prolapse of the valve. In the second video, is performing an annuloplasty, so the technique choose was neocord implantation plus annuloplasty, and then at the end we will check the valve with the saline test. But what about our field? What about the echo result? Look at the first video. We have a perfect coaptation length, of course, more than 8 millimeters, but especially our closure line is posteriorly placed, so far away from the LVOT. In this way, we will avoid one of the most frequent complications in the post-operative, I mean SAM. So no obstruction in the LVOT, no regurgitation. The repair was successful, perfect repair, I would say. Another video, another case, a patient with a form FUST with a chordal rupture on P2 scallop and a severe mitral regurgitation. Look at 3D, at least 3 chordal rupture on P2 scallop. And what about surgical strategy? In this case, the surgeon chose a triangular resection plus annuloplasty. He is performing a resection of P2 leaflet, triangular resection. Then he will put the sutures through the scallop, and then he will perform the annuloplasty. So triangular resection plus annuloplasty, and I want to show you when he will check the valve after annuloplasty with saline test. Saline test means that the left ventricle is filled with saline solution, and look what happened when the surgeon push away the anterior mitral leaflet. So he performed annuloplasty. When he pushed away anterior mitral leaflet, the solution came back in left atrium. It means the repair is perfect and the result is excellent. But again, we need a double check with our post-operative TE. Look at the coaptation length. It's shorter than before because now we performed resection, but the closure line is still posteriorly placed, so far away from LVOT. Again, no obstruction in LVOT and no any regurgitation. So again, a great result and a big success. So performing a mitral valve assessment, in my opinion, is like working in a tailor's shop. And clot is the mitral valve, the string is the echocardiographer, and the tailor is the surgeon. Thank you for your attention and greetings from Lecce.
Okay, thank you so much, Corrado Fiore, for your amazing presentation. Dr. Nanda, would you like to ask or do some comments?
Well, I think that was a very great presentation, explained it very, very well. All the quadrangular resection as well as the triangular resection and the neocordy. I think that was very, very nicely done. I don't think I have any great question for you because it was so very lucid, your presentation.
Thank you, Professor. It's an honor for me to listen to these words from you. Thank you.
Thank you, sir.
Corrado, I have a question for you. Which type of mitral valve pathologies or echo findings predict that the valve is not suitable for repair?
Yes, thank you for your question, Tuğba. I would say that there are many cases where it's very difficult to perform a good mitral valve repair. For example, in the type 1, according to Carpenter classification, when you deal with the destructive endocarditis, it's very difficult to repair the valve. Or also in type 2 with the degenerative and the multi-scallop valve, for example, in extensive Barlow disease, you can have a big mitral annulus calcification. Also in this case, it will be tough for the surgeon. And sometimes in 3B, I mean ischemic mitral regurgitation, because of a huge P3 tethering is not enough just a neuroplasty, but some surgeons prefer also a patch augmentation of anterior mitral leaflet. So everything is up the ability of the surgeon, and of course, it's very important the role of echocardiographer.
Thank you so much.
Thank you for your question.
Great explanation. I would like to introduce our second speaker, but before that, I won't say that if you have any question, and please send us. I would like to say this for our audiences, and we will share our audience's question at the end of presentation. And Dr. Julia Grapsa from London, England, is the next speaker. She is the editor of JACC case report, and Dr. Grapsa's areas of research include valvular heart disease and right heart remodeling, which are the fields that she is a pioneer in. Her presentation is the role of echocardiography during tricuspid valve procedures. Yes, Julia.
My name is Julia Grapsa. I'm the editor-in-chief for JACC case reports, consultant cardiologist at St. Guy's and St. Thomas's Hospital in London. And today my lecture has the title Evaluation of the Tricuspid Valve during Transcatheter Interventions, Tips and Tricks. So the point of the lecture is the tricuspid valve, and the outline of presentation is the anatomy and physiology, understanding tricuspid pathology, tricuspid interventions, the echocardiographic approach, and clinical cases. First of all, as an important advice, you cannot start teasing the tricuspid valve, like touching echo or interventions, unless you understand anatomy and physiology. Right heart is the most anterior part of the heart, and the tricuspid valve is the most anterior and apical of the 4 cardiac valves. You can see that it has 3 cusps, the anterior and septal and posterior, and when the right heart dilates, then the tricuspid valve, the tricuspid annulus, moves towards the anteroposterior direction. And also it's important to remember the anatomical specimens, and especially from the short axis, because this is important for the 3D transthoracic and transesophageal echocardiography. Also, with early studies, we've managed to reconstruct the tricuspid valve, the tricuspid annulus, and the leaflets, and to understand how it changes depending on the pathology of the right heart. The right heart and the tricuspid are almost like the chicken and the egg, as you know. And it's different because if the tricuspid valve has a pathology, then the right heart dilates. And this is important to understand the right ventricular anatomy when we discuss about the tricuspid valve, because the size is 1/3 usually of the left ventricle, but the mass is also smaller. It's 1/6 of the left ventricle. That means the thin wall of the right heart is very sensitive to pressure and volume overload. There is also the interventricular dependence. As you understand, when we have left ventricular pathology, such as mitral and aortic valve disease, then we expect at some point for the patient to develop also tricuspid disease. And don't forget that it's a low pressure circulation. The pressures in the right heart, they are normal up to 25 millimeters of mercury. And when they increase, then the right heart dilates and becomes pressure loaded. As you can see on the diagram, this is the normal and this is the abnormal. And this is the geometry of the right ventricle when compared to the left. When we discuss about the tricuspid annulus, first, Professor Gilles Dreyfus in 2005 described that when the right heart dilates and when we have tricuspid dilatation in the process of severe tricuspid regurgitation, then the annulus dilates towards the anteroposterior direction. And he was the first one to discover the tricuspid annuloplasty. And as during his lecture at the ESC Congress, he described that we need to have a low threshold to perform tricuspid annuloplasty to save the patient from severe TR. As he correctly described, tricuspid regurgitation is not a benign disease, but nowadays it creates a big problem for our patients. But one step further, we discussed the 3D reconstruction of the tricuspid and mitral annulus, which helps us understanding the size of the tricuspid annulus and how it changes during pathology. I won't stay long on the previous slide because I would like to show you how to define the tricuspid pathology. And this is very important because we need to use all our senses. So first of all, what is the reason that the tricuspid valve has regurgitation? First, is there a primary etiology such as congenital or acquired? Acquired is myxomatous degeneration, endocarditis, carcinoid, or rheumatic disease, while actually it could be even traumatic such as pacemaker related. However, many patients, the majority of them, has left ventricular pathology, valve disease or left ventricular dysfunction, while other patients may have pulmonary arterial hypertension. Here, an important advice would be to understand also the shape of the right heart. Does it seem to you volume loaded? Does it seem pressure loaded? Do you think that there is an underlying pathology such as a combination of pre and post pulmonary hypertension? So think of that, all of that, before you actually persuade your surgeons or your interventionalists to intervene on your patient. Now, here is how to assess the tricuspid regurgitation severity. So it may seem easy, however, it's not. And this is because tricuspid valve is sometimes difficult to be obtained. However, I truly believe that in order to perform 3D TOE and all this fancy technology, it's important to understand first the traditional 2D transthoracic echo. We start from the conventional views, how to assess the proximal flow convergence, vena contracta, the jet area, and the 3D vena contracta later on. Important is to keep these key issues in mind. Most important physical factor determining color Doppler jet is its momentum. It's typically lower for tricuspid regurgitation and mitral regurgitation. Reducing the scale may also make the jet appear larger. Regurgitant jets at their direct eccentrically may be underestimated, and also multiple views are necessary for the exact same reasons as they described above. This is a beautiful paper in IYAC cardiovascular imaging that Dr. Hunt, together with Dr. Zogby, they describe actually how to assess tricuspid severity. Also the traditional signs, hepatic vein flow reversal, the density of TR jet, and the jet contour. Use all the dimensions of your eyes and have a good understanding of physics. It's very important. Then it's important to understand what makes a regurgitation severe. So inferior vena cava. Is the inferior vena cava affected by other factors, such as if the patient is ventilated? Also, as we described, the qualitative Doppler, the semi-quantitative measures, and the quantitative measures, such as the effective orifice area, as well as the regurgitant volume, which needs to be more than 45 mL, more to equal, in order to characterize severe. Furthermore, don't forget that we have now severe, massive, and torrential TR, and this helps a lot in understanding the severity that it's appropriate for tricuspid interventions, or, of course, to be discussed in an MDT meeting between surgeons and interventionalists. How about the transcatheter tricuspid interventions? As you can see, we have progressed through the years. This is a slide courtesy of Dr. Maurizio Teramaso from the University of Zurich, and he describes beautifully how from direct sutural annuloplasty and the rings, we have reached to the valve replacement for tricuspid valve. Huge progress over the last 6-7 years. So it's very important to understand that the future is long and bright. And it's important to have a close cooperation between the surgeons, interventionalists, and the imagers to have a successful outcome. Also a beautiful editorial about the challenges associated with transcatheter tricuspid interventions, the anatomy, the clinical, the imaging parameters, and the standard definitions that will evolve as we have new trials coming up. The TriValve registry was important to understand that the tricuspid interventions and the patients had lower 1-year mortality, 23 versus 36%, rehospitalization rate, and composite endpoint rate. Also, the patients that they had tricuspid interventions were associated with greater survival and freedom from heart failure rehospitalization. These data are very important. You can see the graphs and the important difference between the two groups. But also the Illuminate trial is currently enrolling and will randomize participants to receive the TriClip or medical therapy and will evaluate actually the all-cause mortality. Also, the participants who undergo tricuspid valve surgery will be evaluated and the heart failure hospitalizations. But it's also important the fact that they use Kansas City questionnaire in order to understand the quality of life. This is another important manuscript from Dr. Rebecca Hahn that she describes intraprocedural imaging for transcatheter interventions. And now we are going to the tips and tricks on periprocedural imaging. It is important to understand the appropriate patient selection, and this is a great first step to improve outcomes. Assess the tricuspid regurgitation severity. RV volumes and function, pulmonary pressures are important to start your intervention. However, the TriValve registry and a sub-study of that reported that these parameters did not predict clinical outcomes after a transcatheter tricuspid valve repair. But indicators of procedural success were the coaptation gap, central or anteroseptal jet location, and tethering height. The key views for you will be the mid-esophageal, the deep esophageal, and the shallow transgastric and deep transgastric views. Here there are 6 important steps of how we can guide TE and 3D TE for tricuspid interventions. You navigate CDS to tricuspid valve. You get the bicaval view in order to understand the anatomy, and you guide the wire. Then the wire gets adjusted and the clip is rotated in the right atrium. Subsequently, there is a final positioning of the clip at the target size in right atrium, and here you use the transgastric short axis view. It's important for the short axis. And then you advance the system into the right ventricle. Here you will use the transgastric imaging again, and it facilitates the navigation of the clip while providing simultaneous visualization of the clip on the right ventricle. The fifth step is that you grasp the grasping view, and here you need the mid-deep esophageal commissural view, 60 to 80 degrees with biplane imaging, and then you re-evaluate the tricuspid repair with a mid-deep esophageal commissural view, 60 to 80 degrees. Final step, some interesting clinical cases. First of all, Dr. Parekh and colleagues, they describe an interesting case of tricuspid clip on a 22-year-old patient. She had multiple 3 congenital operations, and she came in with refractory right side heart failure. You can see that the patient, despite medical management and IV diuretic management, she had refractory right side heart failure. And on the TOE, you can see that there is a coaptation gap significant, and the patient has severe tricuspid regurgitation. The authors describe how they positioned a mitral clip and into the tricuspid position, which led to a reduction in the degree of tricuspid regurgitation from torrential to moderate with an acceptable gradient of 4 millimeters per mercury. The mean right atrial pressure decreased to 15 millimeters per mercury following the implantation. However, because the risk of tricuspid stenosis, of course, and the patient was young, 22 years old, they didn't proceed to a second clip. Another interesting case is the deep sedation in a patient undergoing transfemoral tricuspid valve repair, but using the Pascal system. Here, if you visit this case, you will see step by step the periprocedural, transthoracic, and transesophageal echo for procedural success during the Pascal. A last case is the tricuspid stenosis in pregnancy. A patient who had a bioprosthetic valve, and she was 23 weeks pregnant with multiple comorbidities and symptomatic severe bioprosthetic stenosis. She came in with refractory pulmonary edema. Here is the bioprosthetic valve, which is stenotic from the 3D TOE, and here is the continuous wave across the tricuspid valve, which seems that there is the steep actual gradient, and it's the mean gradient of 14. The authors describe how they did valve-in-valve repositioning, and this is impressive because the patient was pregnant in order to keep the baby and reach the end of pregnancy. As take-home messages, it's very important before you start dealing with the tricuspid valve, as we mentioned, to understand fully the anatomy and physiology. It's a tricky valve, it's a beautiful valve, and there is a great future ahead for tricuspid interventions. Also, it's very important to understand the etiology of tricuspid regurgitation, and peri-procedural planning is very important. I would suggest to you to follow the tricuspid valve, the publications, the presentations. They are very exciting. Thank you very much for your attention, and thank you for the invitation to this beautiful Congress.
Okay, thank you so much, Julia. It was amazing presentation, and we have learned a lot. Dr. Nanda, do you have any comments?
Yes, sure. I have one comment. I think something which is when you try to assess tricuspid regurgitation by transthoracic echo, many people don't pay attention to the Nyquist limit, which is very important, because if you change the Nyquist limit, you are going to change the area of the jet. And also don't pay any attention to color gain, because when you change color gain, you are going to change the size of the jet also. And thirdly, when there is eccentric tricuspid regurgitation, remember that you lose when the jet strikes the wall of the right ventricle, or the right atrium, you immediately lose the velocity. So you get laminar flow. So you should take into account the laminar flow also, not just the turbulent jet when you try to assess the severity of regurgitation, the jet size. That's how many times when there is eccentric tricuspid regurgitation, we underestimate the severity of regurgitation, which is not really, we don't have to underestimate it. If you take a look at the laminar flow, which is moving with the turbulent flow. That's important. The question I have for you is something we are getting more and more now is pacemaker-induced tricuspid regurgitation. And the question comes up, is the pacemaker embedded in the tricuspid valve? So really you have to go for surgery if there is a lot of regurgitation, or is it free? Do you use 3D echo to look into this problem?
Thank you for the question, Professor Nanda. So, and the point, which was very interesting. So, first of all, when we have tricuspid regurgitation due to pacemaker, we do 3D from the short axis to assess whether the pacemaker lead has practically impinged one of the leaflets. We have seen that on a few patients, and then we went in either most likely with surgery, and we removed the lead, and then the patient had, they tried to repair the leaflet or to replace the valve. We have actually one patient that I'm going to do a TOE on her this Tuesday, that she has this problem, and she has post-pacemaker severe tricuspid regurgitation, and they removed the lead, but now we are considering whether she would be suitable for clip or for surgery. So this is a very interesting entity that we need to do 3D TOE and to get all the parameters to understand the pathology.
Thank you very much. I think that's a very good question. That's really a problem which we face clinically, and 3D echo becomes very, very important in that situation. Thank you so much. Any other questions from the audience?
There is question for Corrado, but I will share at the end of Dr. Thomas Binder's session.
Okay.
No question for Julia so far. So our last speaker is distinguished Professor Dr. Thomas Binder, who is the founder and the chairman of 123 Sonography, and he is the director of Echo Laboratory at the Medical University of Vienna. He will be presenting aortic valve assessment in advanced aortic stenosis.
So hello, everyone. Thank you very much for this kind invitation to talk here on the topic of aortic valve assessment in advanced aortic stenosis. Thanks, Irina, for inviting me. It's a true pleasure. So I want to maybe go back 2 decades and just discuss what the situation was maybe in the 90s. Of course, at that time, it was an exciting time because things happened such as the launch of the Hubble telescope, the Desert Storm, we had the cloning of Dolly, unfortunately, the death of Diana. Maybe many of you remember that was also the time when the euro was introduced, and at that time, we quantified aortic stenosis simply based on the velocities. So things were quite easy at that time, and I remember we had in our lab a chart where we simply had the grading scheme based on the maximum velocity, and that's all we used. And the assessment was quite easy. It was like a no-brainer. You'd have patients with high gradients, and if they were symptomatic or if they had poor left ventricular function, yeah, then you would bring them to surgery. There was no other alternative at that time. But things definitely have changed since then. Now we have TAVI, and the introduction of TAVI truly changed a lot because now we had a second treatment option that was also for elderly patients, and this definitely also changes our approach to the assessment of aortic stenosis. Then speckle tracking and strain came along, and we learned that ejection fraction sometimes is not the best parameter to look at true function of the ventricle, and I will show later how it impacts also the management of patients with aortic stenosis. Yeah, and then the group around Bibarot published a publication or a paper that was really, I would say, a game changer. It showed that you have patients who have normal ejection fraction with severe aortic stenosis who don't have high gradients simply because they have a low stroke volume. Now this really changed a lot, and all of a sudden we started to look more on the hemodynamics of aortic stenosis, and we got all sorts of different calculations that we are using sometimes for research purposes, sometimes in clinical practice, such as valvular arterial impedance, transvalvular flow rates, and projected aortic valve areas, which all, of course, are very important, but sometimes very complex. But what we do now know is that we have various categories of aortic stenosis. Low flow, low gradient aortic stenosis, you all know the situation where you have poor left ventricular function and the gradients are not high. Then you have the pseudo low flow, low gradient aortic stenosis, which looks like low flow, low gradient, but in essence, the patients don't have aortic stenosis. We just have problems distinguishing the two. Then we've got the variation that I talked about just earlier, which is the paradox low flow, low gradient, where you have normal ejection fraction and low gradients because stroke volume is low. And then you've got the opposite of that, which you might call high flow, high gradient aortic stenosis, where we tend to overestimate the degree of aortic stenosis simply because they have hyperdynamic function. And then we've got something that you might call a low flow, low gradient aortic stenosis. Those are patients who have high gradients across the valve despite having reduction in flow. These patients, for some reason or other, seem to be able to still put up with the pressures and still generate enough gradients, probably a ticking time bomb, I would say. And then the case on the lower right is something that I honestly just made up, and I guess low flow, low gradient aortic stenosis would simply mean the patient is dead. But this is actually what we're trying to avoid. So the terminology got quite complex, and it's sometimes very difficult to distinguish the two. And in clinical practice, we sometimes suffer and we have to use all sorts of parameters. So what I thought I would do is I would give you, I would say, a very simple approach, 5 rules that I believe are very important to distinguish the different variations of different forms from each other. I'll just walk you through, and here's the very, very first rule, which I will call no LVH, no severe aortic stenosis. The reason is quite simple if you look at the law of Laplace. The law basically says that if you have a high pressure in the left ventricle, and I guess you all agree that patients with aortic stenosis have high pressure in the left ventricle, the wall tension will be reduced if you either make the ventricle smaller or if you increase the thickness of the wall. In other words, if you get hypertrophy, or put it this way, concentric hypertrophy. So this is the reason aortic stenosis and LVH just simply need to go together. And this are some examples here that show you what I mean. You have on the left top hand side, a patient with severe aortic stenosis, you've got LVH. The same is on the right upper side, maybe an extreme form with very high gradients, massive LVH. And there seems to be a correlation between the degree of LVH and the degree of aortic stenosis. Now on the left side, you have a patient who does not have the severe stenosis based on the mean gradients, but its ejection fraction is reduced. So the question is, can this be severe aortic stenosis? And the answer is yes. Why? Because LVH is present. This contrasts to the patient on the bottom right, where you also have gradients where we cannot tell if stenosis is severe. You also have poor ejection fraction, but here you do not have significant LVH. So at the bottom right, I would be very, very skeptic if severe aortic stenosis is present. So here are the different forms of aortic stenosis. The bottom right would then be a pseudo low flow, low gradient aortic stenosis, while the bottom left would be low flow, low gradient aortic stenosis. But this does not mean that if you have LVH, you have severe aortic stenosis. Why? But because there are many other reasons why you might have LVH. And one typical case is amyloid heart disease. The patient you see here has massive LVH, but he also has very high gradients. So in this situation, both might be present, which is not uncommon simply because amyloid heart disease seems to also affect the aortic valve. Here's another example, a patient who does not have amyloid heart disease, but he also has very severe LVH and also high gradients. This is a patient who has massive LVH due to hypertension. So you will see patients with overproportional LVH if they have additional hypertension. Here's another example of a patient who also has hypertension. He also has LVH, but in this case, the gradients are not high. So again, just the mere presence of LVH does not mean that the patient has aortic stenosis. Let me now come to the second rule, which I think is very, very important. And that's what I was taught way at the beginning of my career. It's always morphology first. So what are we looking at when we look at morphology? Well, calcification. There is now enough evidence, it's in the guidelines. The more calcification you have, the more likely it is that you have severe aortic stenosis. With CT, it's quite easy. You have parameters that you can actually use. With echo, it's a little bit more difficult because you have to use your, I would say, experience to determine the degree of calcification. But calcification alone is not all you need to look at. I would really encourage you to really try to focus on the valve itself and to see whether or not you have some form of opening motion. These two examples here, I guess you will all agree, do not have severe aortic stenosis. Why is that so? Well, because we have residual opening of the aortic valve. You might say, well, this is not very much, but yeah, for you to have severe aortic stenosis, the opening area must be even smaller than this. And there's a rule of thumb that I learned at the beginning, and that was you have to have at least 2 cusps unmobile before you can say that the patient has severe aortic stenosis. It's very difficult to sometimes assess this, but I guess this just shows you aortic valves which are not very calcified, and they also have some residual opening. Those are 2 other examples where we do have severe aortic stenosis. You cannot even look at the opening area anymore simply because there's so much shadowing and calcification there, and that's typical for severe aortic stenosis. You will have different variations in degree, of course, but I guess all of you will agree that calcification and the opening is here very, very poor. The problem is that in many patients, you will not be able to really look at the true morphology from a transthoracic approach. We have elderly patients, we have patients who are maybe not easy to image. So in some patients, you will need to look at a different alternative, and I can only highly recommend to also use TE, which we use increasingly now in our lab, if you want to know how the aortic valve degree of stenosis is. And in reality, in most patients, you will have a little bit less degree of shadowing and calcification in the transesophageal approach. So it will look not as calcified here as it does from a transthoracic approach. On the left-hand side, you can see a patient where we have relatively good opening. You see that opening is quite okay here as well. So those are mild forms. This would be somewhere intermediate where I would probably not be too sure where maybe, you know, the decision is out if it's severe or not. It turned out to be moderate stenosis. And here you see a patient with massive calcification. And this is definitely, you know, I would say a red flag for severe aortic stenosis. So morphology is important. What about 3D? Well, I think I'm not such a fan of 3D in aortic stenosis because the valves are usually not really good to display in 3D. The grayscales are kind of recoded into giving you a sense of depth, and it's sometimes very difficult to really see the valve if there's a lot of shadowing there. But it's something that you can try at least, and we'll see what comes out of that in the future. But just to let you know, yes, we have 3D here as well. Good, so this brings me to the third rule, which is don't trust ejection fraction too much. I know I might be maybe here not, how can I say, maybe a little bit skeptic on ejection fraction, but I think we have to be skeptic, and there's a number of reasons. This is an example why ejection fraction sometimes does not work. Patient with severe aortic stenosis, small ventricle, massive LVH, normal ejection fraction. But none of you will probably believe that this is truly normal ejection, a normal left ventricle function. And if you look at the speckle tracking image here on the bottom, you will see that indeed speckle tracking shows that there's a reduction in strain. So there is more information than just ejection fraction when it comes to assessing left ventricle function if you use other parameters as well. Just to challenge the notion that you might say, okay, every patient with aortic stenosis has poor strain and strain is not really very helpful. It's not true. Here's an example of a patient who also has, as a matter of fact, very severe aortic stenosis, but normal strain. And this following slide, I think, really tells you a lot. And this is just a series of different patients, all with severe aortic stenosis, where you can see both the bullseye display on the top and the left ventricle on the bottom. And what you see is the typical course of events from mild to severe left ventricle dysfunction in severe aortic stenosis. If you look at this image up here, you will realize that the patient has normal global longitudinal strain, but he does not have a normal pattern. You have kind of an apical compensation for what is reduced at the bottom so that you still have normal strain values, but you'll see that ejection fraction is still normal here. Now, the strain values will get less. This is still normal. Ejection fraction will still be normal, but then all of a sudden you will see a point where strain, global strain starts to get less, but you will still have normal ejection fraction. And here you have an example of a patient who already has significant reduction in strain, and this is when ejection fraction starts to drop. So the bottom line is that you will have a reduction in EF only in the later stages of myocardial dysfunction. This is why strain is such an early marker of dysfunction, and that's why it's also so valuable in aortic stenosis. Of course, strain can also be used to look at the degree of left ventricular function in a very, very graded manner, which is sometimes more difficult with ejection fraction. But let's take a look at what this implication is. And if you look at the study here, you will see that those patients who have preserved longitudinal function in the setting of severe aortic stenosis have a much better prognosis than those patients who have an impaired longitudinal strain. To summarize the problems, yes, we talked already about the small ventricle, which is always more hyperdynamic. It compensates basically for the small size of the ventricle. We have early loss of longitudinal function. It's a poor prognostic factor if strain is low. And don't forget that dysfunction of the left ventricle might not be related to aortic stenosis, but it could also be related to maybe other forms of myocardial disease or myocardial infarction, for example. And then the quantification issue and technical issues, I guess you all know these problems of ejection fraction. And finally, we're only looking at patients at rest, so we do not really know what the contractile reserve of the patients is. So be cautious when you use ejection fraction, when you assess patients and say, oh yeah, they have normal function just because we see a normal ejection fraction. The fourth and very important rule, and here I guess I'm a little bit, I would say, controversial, is don't trust calculations of the aortic valve area. Why? Well, look at this graph here. This is the correlation between the aortic valve area calculated with help of the continuity equation versus the gradients. And you will see that there's a large group of patients in this box and in this box who actually don't match. Now, you might say, okay, a number of these patients are simply a factor of low flow, low gradient aortic stenosis, which is definitely true, but we know from the literature that 20 to 30% of all patients have discordant grading based either aortic valve or the gradients. So there is something wrong here. And I guess we all agree that there's a methodological problem. That, you know, if you look at the discussion, if it's the aortic valve or the gradients who are wrong, yes, the gradients also have their pitfalls, but basically it's one major factor that plays a role, and that is the width of the LVOT. To exemplify this, here is just an example of a calculation where you use the same parameters for the LVOT velocity and for the aortic valve velocity, but we just changed the LVOT diameter a little bit by 3 millimeters. Look what happens. Here we have 21. We have an aortic valve area, which denotes severe aortic stenosis. And we've got an index of only 0.4. If we now just change this, all of a sudden we have an aortic valve area of 1.1, which is not severe aortic stenosis, and 0.5. So this just shows you that small changes make a huge difference when it comes to the LVOT diameter. And 3 millimeters is not very much. It's just I would say, a very, very small motion of the cursor. The question is, and this is something that I've been seen doing quite frequently, is should we cheat? Should we just a little bit over measure the LVOT just so we get to an aortic valve area that fits to the true gradients? And the reality is that there's an argument for that, because you can say, okay, the LVOT is not round, and we should be measuring a little bit more to get the true area. But still, it's just something like, you know, we're just guessing, to be honest. And in reality, I think there's something that we can do which is much better, and that is to look at the LVOT velocity. which is part of of course, the equation. But the LVOT velocity gives you so much information about the true hemodynamics of aortic stenosis. Here's an example of a patient who has an aortic valve area, a velocity time integral of 8.8, which is very, very low. If you see this, you probably don't even need to measure the LVOT diameter. This is very low. This is kind of low output, and which in the setting of aortic stenosis already means that the gradients cannot be taken as they are, that you're probably going to underestimate the severity of stenosis. I would say these patients are a ticking time bomb. Now, you can go further and use this LVOT velocity time integral and then calculate the stroke volume and then divide it by the body surface area, and you'll get a value which I believe is probably one of the most important parameters that you should put in your report, and that is the stroke volume index, where we have a cutoff value of 35 milliliters per square meter. Now, this you will see in patients who have low flow, low gradient aortic stenosis, and in paradox low flow, low gradient aortic stenosis. If you have a stroke volume index below 35, you can already kind of sense that they have higher global afterload. They usually have more concentric remodeling, so small ventricles. There is evidence of intrinsic dysfunction, and they also have a worse prognosis. And the LVOT velocity itself is also very helpful if you're performing stress echocardiogram, because this will tell you if there's a contractile reserve or not. So aside from now the maximum velocities and all the other calculations you do during stress echo, I would just encourage you to really look at that parameter, because it will tell you about whether or not the patient has an increase in contractile function during the stress echo. And here you do not need the stroke volume alone. You will already be able to just see the different velocities of the curve. So the VTI alone is here already very, very important. Now, there are certain pitfalls, I must agree, and it's definitely so that the velocity time integral depends on the width of the LVOT. Yes, with aortic regurgitation, you will have higher velocity time integrals. You might not even be able to measure them because you have LVOT obstruction, either fixed or dynamic, and there's a number of technical issues. For example, if you move the cursor a little bit too close to the aortic valve, you'll get the aortic valve signal. And it's also affected by heart rate. Very, very important. That's why you should also put the heart rate into your report so that we better understand under which conditions the parameters were measured. This brings me to the last and also very important rule, and that is, again, very provocative, I would say, is who cares if aortic stenosis is severe anyway? You know, those patients where we can quantify it, yes, good, but there will be a group of patients where we're kind of is it in the between or maybe moderate. And I'm saying this because in the age of TAVI, things might change. And imagine, for example, you have a patient who had a myocardial infarction without aortic stenosis. And what you're trying to do here is you're trying to prevent remodeling. And we know that we'll give them ACE inhibitors and all sorts of medications to actually lower their blood pressure, because we don't want to have a high pressure burden on the residual myocardium, because we're afraid that there will be remodeling. But what about in aortic stenosis? No matter how much ACE inhibitors we give, we will not get the pressure down. So maybe in these patients, it makes sense to also perform TAVI, even though they might not have severe aortic stenosis. Gradient of 20 means 20 millimeters higher systolic pressure. Now, of course, the decision here is out and we still don't know the true answer, but I just want to maybe throw this at you and make you think a little bit that sometimes it's just not the severity alone which should drive our decision. Don't forget that many patients will have aortic stenosis which progresses, so I think it's important to follow the patients closely. And if we see that there's a rapid progression in aortic stenosis, it's quite apparent that it will not take long until they have severe aortic stenosis anyway. And if you wait too long and the patients get older, then the risk of operation will be higher. So maybe it's better to just time it, anticipating that the problems will come. And we also know that sometimes patients who are have severe aortic stenosis or moderate stenosis, whatever, and we're bringing them to surgery, there will be a time delay until we will finally do the intervention anyway, and patients can also die on the waiting list or get further impairment of left ventricular function. And then finally, let's not forget that patients with aortic stenosis, even if it's only moderate or mild, has detrimental effects, and this is a study that we published many, many years ago that shows this. If you have mild to moderate aortic stenosis, you have a 1.8 times higher mortality than expected. So mild to moderate aortic stenosis is not a benign condition. So with all of this said, I think we can make a little bit more sense out of all these different forms of aortic stenosis and also help you to drive decisions. And for me, the bottom line is it's sometimes more important to really use common sense and just clinical judgment and not to use too many numbers and too many calculations, which all of which have certain pitfalls. So I thank you for your attention. I hope you got something out of this lecture. Again, many, many thanks for allowing me to speak here. And I'm here for any questions that you might have.
Okay.
Okay.
Thank you so much for your excellent presentation, Dr. Binder. I want to give microphone to my Professor C.Nanda.
Okay, can you hear me? This is C.Nanda here. And Tom, that was an excellent presentation on a difficult subject. I completely agree with you about the unreliability of aortic valve area by continuity equation, especially when the LV outflow tract is narrow or borderline narrow. And I think if you look at the literature, everyone depends on aortic valve area by continuity equation. It's really not a good way to go. And I think when there is normal function and normal flow, I rather depend on the gradient, mean gradient, rather than on aortic valve area. So that's the comment that I wanted to make. The other thing is that what about the flow rate? Do you think, I mean, stroke volume is one thing, but as you know, some more literature has come in, especially from Roxy Senior from United Kingdom, that flow rate might be important. Do you have any comment on that?
Yes, first of all, again, thank you very much, Tuğba, for inviting me to this lecture. It's a true honor. And coming back to this issue of aortic valve area, yes, I think, you know, we've been using this for so many years and we've been used to putting that in the report. We just have to sometimes rethink. And I think what the important thing is, and you touched on it, we need to assess each patient with respect to the flow conditions. We know exactly that if you have a patient with mean gradients which are elevated, then everything is clear anyway. But if we have a situation where we suspect that something is not correct with flow, and this is the LVOT velocity and the flow rate, as you just mentioned, those are two conditions where you have to be very, very cautious. Yes, we've started to do a lot of, evaluations of flow rate as well. And they have given us much more information on the true hemodynamics and to much better understand why patients have gradients. And we do see discrepant results. You know, sometimes patients who have, just low flow rates, which kind of explain some of the hemodynamics.
Great. Any questions from the audience?
Yes, we have some questions and many compliments. One question from Macedonia, Irina Kotlar, asking to Dr. Binder, do you use LV strain when deciding about operative and transcatheter intervention on aortic valve in patients with severe aortic stenosis and no symptoms?
This is first of all, hello, Irina. Thanks for your question. Well, this is a very difficult topic. I'll tell you what I do. The issue here is that it's not yet in any way in the guidelines, and we don't have, at least not the recommendation at this point, to use it to decide when should go for surgery or not. But I strongly and I heavily use this parameter, especially when I see patients who start to have a reduction in strain and their ejection fraction is not down yet. That's to the point where I check these patients much more frequently. And if I do see that the patients start to deteriorate even further with strain, then to be honest, yes, I would send them to surgery. But this is something where I'm maybe going a little bit ahead. At least in my experience, I've seen that it usually does not take long until patients start to get symptoms once strain gets less. The only important thing is you need to be sure that your strain values are reliably obtained. You need to be sure that the values are correct, and they need to be reproducible. So if you have these factors in place, then it definitely is a very, very good parameter. And just one last comment, because I think it's so important. You have to understand if you have a small ventricle, this small ventricle needs to be hyperdynamic to generate a certain degree of stroke volume. This is why you will always have higher than normal ejection fraction. So I'm challenging a little bit the notion that we should use the same cutoff values for left ventricular dysfunction in patients who have aortic stenosis in concentric ventricles. And that's why I think the strain is such an important add-on parameter. And there's actually data out there that shows that patients that are operated with a reduction in strain do not recover completely in some instances, opposed to those patients who still have a normal strain. So I think these are all things that you need to consider.
Thank you so much for your comprehensive explanation. We have one question for Corrado Fiore from IYAC. They are asking, sorry, I try to read. Can you talk about dynamic mitral regurgitation? I mean the management when it became mild. Meanwhile, see it's severe after a few minutes under loading.
Sorry, I didn't understand.
They are asking about your experience. They are asking about your experience about dynamic mitral regurgitation. Could you hear me? Could you hear me, Corrado?
Now, yes, now. Repeat,
yes.
Please.
They are asking you from IYAC, what is your experience about dynamic mitral regurgitation?
Yes, after repair. They won't know after repair.
After repair, didn't explain, just
yes,
maybe.
Maybe after repair, one of the most frequent complications is the post-operative SAM. So one of the ability of the surgeon is to avoid SAM and so dynamic regurgitation. Sometimes you can avoid it after a repair just with drugs. I mean beta blockers or hydration. But when you have a real SAM, for example, when you perform a restrictive angioplasty with a long anterior mitral leaflet, you have to check again the valves, and any drugs can save you.
Thank you.
Can I just add something to this, maybe? Is that okay?
Yes, please.
I think, you know, that the issue of dynamic mitral regurgitation is a very important one because, you know, we have patients who we have maybe moderate MR and we're not sure if they really are symptomatic due to the moderate MR. And then you know, you see these patients coming back and all of a sudden MR is much more. I think the bottom line is it's very important to also measure blood pressure in these patients. I think it's important to do this because this is one of the most common causes for dynamic MR. I've seen patients, you know, coming in with exactly the situation I just outlined before. Why? Because the afterload is higher with hypertension. And it's something you should consider.
Yes.
Thank you so much. And one more question for Julia. Julia, as you have summarized very well, many new percutaneous techniques are being developed for tricuspid valve. Based on your own experience, which of them do you think will be more successful in the future?
This is a bit complicated to answer because it's multifactorial, and especially in the tricuspid valve, we are taking into consideration the right ventricle, the function. So it depends because we have tried a lot TriClip. There are big studies that now we can see significant efficacy of the TriClip. So we have the data. But sometimes cardioband, depending if you want to reduce the tricuspid annulus, might be more effective. Or of course, if, as Professor Nanda said, that there is a perforation of the tricuspid valve, maybe then surgery would be the only option. So, you know, it depends on the pathology. So I know that we will have a bright future. That's the only definite thing. But then it depends on the right ventricle and the etiology of the tricuspid valve. That's why I said that in order to assess the tricuspid and to understand the intervention, you need to understand very well the anatomy and the physiology and what makes the leak, for example, the problem.
Thank you so much. I totally agree with you. Do you have any comments, any questions? Nanda? Professor Dr.
No,
Nanda?
I think there's a very good discussion and very good talks by all the three presenters. So it was really a pleasure to hear them. And Tuğba, it's nice to have you as the co-moderator with me. It's a pleasure and honor.
Same.
Okay. Thank you.
And now we are going to finish our session. This evening, we try to give you practical tips and tricks for assessing valve in a limited time. I would like to thank all wonderful speakers and Professor Dr. Nanda who shared their experiences with us. Taking time out of your busy and personal and professional schedules means the world to me. We hope to have a chance to meet you in person next year. Good evening to all.